but definitely a massive surge of disease at present moment. Patients are affected after recovering from COVID. Rising trend noticed all over India, and every day multiple cases reported different parts of India. In our region, we may get quite a number of cases in coming few days. Early diagnosis and treatment is the key, as mucormycosis has a very high fatality rate. Today, we have eminent speaker and panelist in this webinar. Dr. Brojen Sarkar, our senior ophthalmologist and well-known and respected member, will chair this session. Dr. Santosh Sonawar. It's a well-known name in the field of ophthalmology in India and abroad. It is very difficult to present his achievement in just 3-4 lines. He is a pioneer in ocular plastic surgery, orbit, and ocular oncology in India. He trained in RP Center and Wills Eye Hospital, Philadelphia, established ocular oncology at LBPI Eye Institute, was associate director of LBPI and established the residency program. Currently, he is heading the oculoplasty and oncology at the Center for Sight and CFS Education. Awarded Shanti Sharup Bhatnagar Award by the government of India. I think only 2 ophthalmologists got this award. He got the Jerry Shield Award by the Asia Pacific Academic of Ophthalmology, and he is the first Indian to achieve Lifetime Achievement Award by the American Academy of Ophthalmology in 2019, and Honorary Fellowship Royal College of Ophthalmology UK in 2020. He is the currently editor of India Journal of Ophthalmology. Welcome, Santosh, in this webinar. Thank you for giving us some time in your busy schedule. Our next speaker, very well-known, Dr. Amitabh Rai Chaudhary, is a professor and head of the ENT Vivekananda Institute of Medical Science and Kolkata, visiting otolaryngologist, AMRA Hospital, Kolkata. He is the president of Association of Phonosurgeon of India. He has a number of publication in international and national peer-reviewed journal. He is a co-editor of the textbook of laryngology published by J.P. Brothers in 2017. And he's a monogram of cadaveric dissection of manual on endoscopic sinus surgery. He's invited faculty at the European Otolaryngology Congress in Brussels 2019. He's a mentor of many surgeons and deliver oration and keynote address in many state and regional conference. Welcome, Dr. Amitabh Rai Chaudhary, and I must thank him joining this webinar apart from his illness. And our very well-known face, one of the speaker is Dr. Arjun Dasgupta, ENT head and neck surgeon, CMRI Hospital, Kolkata, and he is an accomplished surgeon, a leader, and a versatile actor. And his special interest in endoscopic skull-based surgery. Today's webinar will moderate by Dr. Anirban Bhaduri. He currently head the Oculoplasty Ocular Oncology Service of Shushruth Eye Foundation, Kolkata. He is ex-fellow of LBPI, Ophthalmic Plastic Surgery, Orbital Disease and Ocular Oncology, and established Oculoplasty Oncology Department in CMRI, Calcutta. I request Dr. Kajol Ghosh, the President, West Bengal Ophthalmological Society, to say a few words. Over to Dr. Hello.
Hello, শুনতে পাচ্ছো?
Yes, Dada, a few words from you regarding our...
Well, welcome to this webinar organized by OSWB. It's a timely event, a time event. You know, everything that I wanted to say has been said by Arup. The recent upsurge in mucormycosis is really a problem to all of us, and it is affecting these COVID-19 patients, COVID after they are recovered. So, I mean, everyone, the frontline workers and the doctors are doing hard to tackle the situation. And we have now today galaxy of speakers from local and national level will shed light to us about this dreadful disease and will make our journey smooth in this difficult situation. Thank you.
Thank you, sir. I just hand over the session to moderator the session to Dr. Anirban Bhaduri. And Dr. Sugato, please do all the questions in the session. Thank you.
Yeah, I am keeping track of them.
Yeah. Anirban, I'll unshare.
Are you?
I'll stop sharing, or I'll share.
No, I think you can put forward the panelist slides as well, okay. And Anirban can.
These are our panelists.
Yeah, Anirban can introduce them if he wants to. I just shared the slide here.
Anirban, I unmute yourself, please. Unmute. Please unmute.
Okay, am I audible now?
Yes, yes.
Okay, thank you, Arup, for beginning the session. So among our panelists, we have Dr. Joyita Das, an eminent oculoplastic surgeon. She is a consultant orbital and oculoplastic surgeon at the Disha hospitals, and she covers several of their hospitals. And she was a former consultant in Sadguru Netrana Chikitsalaya in Chitrakoot. She's the reviewer for several journals, the Orbit, BMJ case reports, as well as the BOJ, and she has numerous publications in international and national journals. Joyita, welcome. And then we have Dr. Rajesh Majumdar Chaudhary. Okay, Dr. Rajesh Majumdar Chaudhary, who's a senior oculoplastic surgeon in Kolkata. He's a very passionate person in general, passionate about everything, not only oculoplastic surgery, but also takes a lot of interest in mental health and is an avid trekker. And we also have Dr. Saurabh Sannal. Dr. Saurabh Sannal was in the army. He has actually mentored me into taking up oculoplasty. He was the inspiration because of which I actually went and did a fellowship with Dr. Hanawar. Saurabh is the director of the Citizens Eye and Healthcare in Serampur, as well as the director of Drishtideep Eye Institute in Dankuni, and he covers the entire spectrum of ophthalmology. I haven't seen another person like him. Saurabh, welcome. We also have Dr. Tushar Kanti Ghosh. We actually come from the same college. Dr. Ghosh is an ENT surgeon. He's the director and founder of the Ghosh ENT Foundation in Salt Lake. He's also senior consultant in the Apollo Hospital, as well as a visiting surgeon in AMRI and Columbia Asia Hospitals in Salt Lake. He again has numerous awards to his credit and has also been awarded with the Mother Teresa Gold Medal and Doctors of Letters for his work in social service and contribution in the field of health. Welcome, Dr. Ghosh. We'll begin with Dr. Santosh Honavar. Sir will be talking to us about the management of orbital mucormycosis. Over to you, Dr. Santosh.
Thank you, Anirban, and I thank Arup and Sugato for taking initiative to organize this timely, I would say very timely symposium to sensitize everybody about this particular condition. I think West Bengal is not seeing so many cases at this point in time, but as the incident goes high, you are likely to see that is what is happening in Telangana. We have cases that are rising in number by the day, and in Maharashtra, I think they have reached a peak already. So this is what we could collect in February 2021. You know, just about 4 months ago, only 6 cases between Hyderabad and Mumbai, and we thought it was something very novel, so we published it. Just a matter of 4 months, everybody has seen more than 60, 70, 100 cases, especially in Maharashtra, Madhya Pradesh, and Gujarat. Wards are full of mucormycosis with COVID. Earlier, before COVID era, incidence was very low. We would possibly see one case in 2 or 3 months, and mortality was even high at that time, 50%. What was known then was delay of 6 days would double mortality. But with COVID and mucormycosis together, even a 24-hour delay can double mortality. So it's very rapidly progressive in the current situation, and that is very alarming. These are the risk factors: uncontrolled diabetes, neutropenia. Everyone knows about the role of elevated free iron levels, patients who have undergone bone marrow or solid organ transplantation, and malignancies. But the most important risk factor has now come to be COVID-19. Mechanism: angioinvasion, mycotic thrombosis, and ischemic necrosis, and that is the route it follows to invade various structures. Why does that happen in the presence of COVID? There are various reasons, one of which is decreased immunity per se. Associated comorbidities such as diabetes obviously diabetics have a higher risk of developing a COVID infection, and they also have a high risk of developing mucormycosis. Decompensated pulmonary function, use of steroids and tocilizumab, which are inherent in the management of COVID. And it's also more commonly seen in severe diabetics. It is also already known that in patients who have COVID, there is bacterial and fungal secondary infection. Secondary fungal infection was supposed to occur in the middle and late phases of COVID, and even following resolution of COVID. And that is exactly what mucormycosis is following. The last case that I saw was a young individual who had COVID 3 months ago, and he developed post-COVID diabetes mellitus, which is known to occur because it attacks the pancreas, and he developed mucormycosis 3 months later. So they can go on to develop mucormycosis even in the late phase, and mortality is higher than otherwise. It's more than 60%. Why does this happen? There could be two sources. One is exogenous, and the second one is endogenous. Mucor is one of the normal commensals of the GIT, but it is also seen in nasopharynx and paranasal sinuses. There is breach in the mucosal barrier in COVID that is proven now, and the exogenous source could be anything, including oxygen catheters and the humidifiers that are being blamed. This is a nice article that was published which shows that there is impaired mucosal immunity at the point of entry, which is the nasal mucosa, and point of proliferation, which could be nasopharynx and the sinuses in COVID. And that continues to remain breached for a very long time, for even up to 6 weeks to 3 months following COVID infection. And that could be one of the contributing reasons. Having collected all the cases that are recently published on this particular aspect, we have come to summarize these aspects: diabetics, patients who have received steroids and tocilizumab, for elderly more than 70 years. Currently, however, with the second wave, we are seeing patients who are even in the 40s and 50s developing mucormycosis. Patients who have severe COVID-19 needing mechanical ventilation for more than a week and prolonged supplemental oxygen for more than 3 weeks. It can occur concurrent along with COVID infection or in the early and intermediate recovery phase, or even prolonged, and life salvage is less than 40%. The ophthalmic and associated symptoms: the first symptoms, since it's rhino-orbitocerebral, first symptoms are generally nasal stuffiness and bad odor, nasal discharge and white ulcer, which can be seen on diagnostic nasal endoscopy. But these symptoms may be common to COVID infection as well. Use of oxygen prongs, etc., can cause mucosal dryness and crusting, and that should not be confused with the symptoms of mucormycosis. Bad odor is somewhat more specific to mucormycosis. Patients then go on to develop progressive eye, facial pain, and headache, which is progressively worsening. If it is a pain that goes on remission and then comes back, that may not be suggestive of mucormycosis, but continuously worsening pain is suggestive. Then they develop eyelid and periocular edema, followed by hemifacial edema. Then there is progressive discoloration of the periocular area and the face. And discoloration initially starts with pallor because of ischemia. Then it goes on to a violaceous hue, and finally blackish discoloration and eschar formation. That follows the stages of ischemia. Patients who have developed proptosis could be either because of inflammation itself, because of necrosis, and proptosis could also be because of a space-occupying lesion caused by the fungus. But proptosis caused by inflammation is more common than proptosis caused by space occupying lesion. In proptosis caused by inflammation, there is what is called a triangular sign. That is, posterior aspect of the eyeball is triangulated and the optic nerve is stretched, and the fat could just have an altered signal intensity, but there is no mass itself. But when the posterior or the mid or the anterior orbit is opacified, then that means that there is ischemia in that area, and there could also be a fungal granuloma formation. Sudden onset of loss of vision is one of the symptoms, that is central retinal artery occlusion, and ptosis and ocular motility restriction are late phases where patient is already has involvement of the superior orbital fissure and the orbital apex. Altered sensation in the infraorbital nerve area and the supraorbital nerve area have also come to be reliable symptoms in these patients. This is how we see these patients with eyelid and periocular edema, discharging sinus because of secondary bacterial infection. This patient developed sudden onset ptosis, and by the time he came back with the scan, he had developed chemosis as well. That how rapidly within 2 or 3 hours they progressed. This lady presented with ptosis with complete ophthalmoplegia, and that is one of the signs of mucormycosis. She has no proptosis at all, very minimal proptosis, no congestion, but ptosis. Because her mucor, so what happens is if it enters through the nose, it can go to the orbit either by the nasolacrimal duct, that will be middle orbit, medial orbit, or it can breach the lamina paprizi of ethmoid and get into the mid orbit. And it can also go to the superior orbital fissure from the posterior orbit itself without causing much of proptosis or inflammation. So these patients develop sudden onset ptosis more commonly. This is a young individual presenting with CRAO, does not have any other sign except for thickened paranasal sinus mucosa, which was enhancing, and there are some areas of dropout as well. But the first MRI sign is supposed to be a black turbinate or a silent turbinate, where the middle turbinate, which is most commonly affected, stops enhancing because of ischemic necrosis, and that is one of the earliest signs on MRI. All this happens because of the proximity of the structures of the orbital apex, the ophthalmic artery, and the superior orbital fissure, and very close by is the inferior orbital fissure. So all these signs can be very easily explained. Now on CT scan and MRI, what is considered currently is the most useful tool is contrast enhanced MRI and MR angio, because that gives you the exact pathology, whereas CT scan can lag behind the MRI, and MRI is come to be the gold standard. The earlier signs in the orbit could just be increased thickening of the medial rectus muscle and edema around the medial rectus muscle. Otherwise, patients can have ethmoid sinus involvement, which is the most commonly involved sinus, and it can directly go into the orbital apex and the cavernous sinus. Very rarely do we find only the orbital apical involvement. In the coronal scans, you find thickening of the nasal mucosa, thickening of the paranasal sinuses, or opacification of the paranasal sinuses. This patient just has thickening of the nasal mucosa and fluid level in the paranasal sinus, and this is a fully blown case with orbital as well as maxillary sinus involvement. So when a patient comes to an ophthalmologist first, we don't have to waste time in scanning. The first thing that we do, if you're well versed with endoscopy, you can do a diagnostic nasal endoscopy and go to the area of affection and take an endoscopy-guided swab that is most diagnostic. Suppose you're not well versed with endoscopy, then at least reach the middle turbinate and take a nasal swab, nicely rub it in and take a good swab and send 2 samples. One is for a smear for the pathologist to do HND, PAS, and GMS. And the second is for a microbiologist for KOH and calcium fluid white. Of course, culture is important. But if you get a bit of tissue, then that can be sent to the pathologist for squash and imprint, and also frozen section. With these 2 rapid pathology modalities, you can get a diagnosis within 15 minutes. KOH, calcium fluid white, can give you a diagnosis in 10 minutes. Smears can also give you a diagnosis in 15 minutes. So if you have this already, then the management becomes very easy. Then the patient goes for a scan, MRI preferred with contrast. If not possible, either a CT scan or a non-contrast MRI would do. And if you want to take the best swab, most diagnostic yield is often not got at the area of necrosis, but around it. So around the area of necrosis, erythematous or violaceous area will give you the best scope for getting the fungal sample. Of course, what is also important is culture, for which it may take time. But what we're realizing now is that mucormycosis, which used to take 5, 6, 7 days to grow, now with this, I don't know what has changed, but it can grow within 24 to 48 hours. So rapid growth on culture media, separate dextrose agar is also reported. And serology and PCR-based diagnostics also help. So based on our findings, we propose this classification system where stage 1 is the nasal mucosal involvement, stage 2 is paranasal sinus involvement. But since we are oculoplasty surgeons, what is important to us apart from paranasal sinus involvement is the orbital involvement itself. Since the nasolacrimal duct and the medial orbit lamina peprasia are the point of entry, it first goes to the medial orbit, at which stage you will only find conjunctival chemosis, restriction of the medial rectus muscle, and on scan you will find thickening of the medial rectus muscle. Diffuse orbital involvement goes to stage 2, but even in stage 2, vision is unaffected. And in stage 3, there is central retinal artery or ophthalmic artery occlusion and superior orbital fissure, inferior orbital fissure syndromes. Loss of vision is seen in stage 3, and stage 3D is bilateral orbital involvement. CNS involvement is classified in stage 4. This is the largest series of mucormycosis, not COVID related, of course, which clearly tells us that if you combine surgery, which is aggressive paranasal sinus debridement, and or exenteration if required, and amphotericin B, then you have 70% life salvage. The same philosophy can be applied to COVID situation as well. So delay in treatment is not warranted at all. If a patient based on symptoms seems to have possible rhino-orbitocerebral mucormycosis, then the first step that you do is to do a diagnostic nasal endoscopy and a swab and a scan. If there is no supportive evidence at all, then these could be non-specific symptoms, but you still don't give up and closely observe these patients on supportive treatment. If they worsen at all, then it goes to probable mucormycosis. Suppose they don't worsen, they improve, on the contrary, then mucormycosis is unlikely. If a patient has possible symptoms and also supportive evidence clinically and on diagnostic nasal endoscopy and MRI scan, then it is probable mucormycosis and you immediately start on treatment. True one, of course, you have to start on treatment immediately. And the first line of therapy is not surgery, but immediate initiation of amphotericin B liposomal 5 mg per kg body weight. If CNS is involved, 10 mg per kg body weight. And if liposomal amphotericin is not available, then deoxycholate or lipid complex are acceptable, but they have a higher chance of renal toxicity and are less effective. And in the meanwhile, prioritize the patient for surgery. Some of these can be done under local anesthesia. Even exenteration can be done under local anesthesia because this is devitalized tissue. But those needing GA may need a little bit of preparation because of their comorbidities. Now, if the patient has stage 1, 2, or 3, A to B, with minimal orbital involvement and vision preserved, then you go for early sinus surgery. And for the orbit, you can give retrobulbar amphotericin 3.5 mg per ml on 7 consecutive days, along with sinus irrigation following sinus surgery. If the patient improves, then after amphotericin B, 2 to 4 weeks is recommended. You go on to oral posaconazole that will continue for 3 to 6 months, depending on the aggressiveness of the disease and the radiological stability. If the patient has stage 3, A to C, and the disease is progressing within 72 hours after initiation of amphotericin, you can go for orbital exenteration, followed by the rest of the protocol as earlier. If the patient has stage 3C to D, that means orbit is extensively involved, but limited CNS involvement, then you go with orbital exenteration along with paranasal sinus surgery. This can be combined approach, and rest of the management is as described. If a patient has CNS disease, if the patient is fit for surgery, then you do everything else that has been said already. Paranasal sinus surgery, orbital exenteration. Although these patients have a relatively poorer prognosis. Up to cavernous sinus thrombosis, reversibility has been shown, recovery has been shown, and mortality has been in the range of about 50 to 60%. But when it is beyond the cavernous sinus or bilateral involvement, then mortality is extremely high. But what is also important is maintenance therapy and strict diabetes control. So indications for orbital exenteration as ophthalmologists are mainly predominantly orbital involvement. no or minimal extension to cavernous sinus. Unilateral cases were the standard indication earlier, but now we are doing bilateral exenteration also if it is life salvage in question, especially in patients who have no vision bilaterally. Worsening or no improvement within 72 hours after starting full dose amphotericin B. And of course, it's the surgeons and the family decision. Now, this is the patient who has undergone orbital exenteration. You can preserve skin. If you can't preserve skin, that is also acceptable. What is important is to do a good orbital exenteration with apical clearance. Wherever there is necrotic tissue, that has to be very nicely debrided, and you can give an exenteration processes. This is one patient who actually presented with complete ptosis with orbital apical involvement. We did not do exenteration in her, just the medical therapy after paranasal sinus debridement, which was also not very aggressive. She recovered quite easily. So some of these patients actually recover very well with paranasal sinus surgery as well as systemic therapy without needing orbital exenteration if the patient does not have predominant orbital involvement. Now, preventive measures, of course, judicious use of corticosteroids and tocilizumab are the prime anchors in the management of preventing mucormycosis in a situation of COVID. Of course, diabetes control. And since COVID itself is diabetogenic, we have to take additional measures to control diabetes. Strict aseptic precautions in administering oxygen. Some of the treatment teams have questioned it, but I believe this is an important factor, because there is enough proof that water that is used in the humidifiers and the oxygen catheters themselves can grow fungus if they are not used aseptically and are not replaced in 24 to 72 hours. Personal environmental hygiene is important because mucor is everywhere. As we speak, we are breathing in mucous pores, but we are immunocompetent. But in an immunocompromised individual or patient who has lost its immunity of the mucosa, it is important that they should use a barrier mask even post recovery of COVID. And prophylactic use of posaconazole is being advocated in very high risk patients who have had more than 3 weeks of ventilation, more than 3 weeks of oxygen support, patients who continue to be on systemic steroids for a prolonged time, uncontrolled diabetics with ketoacidosis, prior history of risk factors, etc. Posaconazole is a possibility. There is no proof to this effect. And we know that corticosteroids are to be used only when indicated. Indian indications for corticosteroids are slightly lax, but in UK, NHS has very strict guidelines for use of corticosteroids, and the duration. Duration is very important. We have patients who have used steroids for 3 to 6 weeks for coming with mucormycosis. And early diagnosis is a key. High index of suspicion. ENT consult at a very appropriate time and an ophthalmic consult, and early intervention with amphotericin B and appropriate timing for surgery are the key to success. Thank you so much. And if you want to read the IGO article, you can, this is a QR code, you can take a picture of this on your mobile and read to the article. You can download it. It's not yet published, it is in the process of publication. So this will give you the pre-publication version of the article, which describes the protocol as well. Thank you so much.
Thank you, Dr. Honavar. That was a very comprehensive coverage of the disease. As an ophthalmologist, we would be seeing stage 3 disease. And exenteration, as you said, it's essential in a certain set of patients. And the problem is that it's an extremely disfiguring surgery. Bilateral exenteration is something that all of us as surgeons would dread to do. The other good thing that has come out in this time is the use of retrobulbar injection of amphotericin B, as you pointed out, for patients who do not have such extensive disease. Sir, what I wanted to ask you is that in this current scenario, when you have COVID-19, we also have other patients who come who need intravenous methylprednisolone or steroid therapy for other orbital conditions. We are actually placing these patients in harm's way.
Well, I mean, yeah, if they have had COVID, so we have to be very clear about asking for a history of symptoms. Some of them may not even get tested. So we don't know whether they have had COVID or not. So even if they have had symptoms, then intravenous methylprednisolone is to be deferred. If they're diabetics, we defer intravenous methylprednisolone. For chronic conditions such as non-specific orbital inflammation or active thyroid eye disease, we defer it. But what is found is oral azathioprine is okay. So there are reports that oral azathioprine does not use that mechanism which the fungus uses. So immunosuppression with oral azathioprine is acceptable, whereas use of oral steroids or systemic steroids is prone to have higher risk.
Thank you, sir. Do we have questions for Dr. Santosh?
Can I ask a question which is asked by Dr. Manish Tote from Amravati? Sir, there are not many cases of mucor abroad. Why are so many cases in India?
Well, see, in the second wave, I think there has been some mutation in the virus, which is causing a higher degree of loss of mucosal immunity. That is one. Second is that in rest of the countries, the use of steroids is audited. It is an audited treatment intervention. Tocilizumab is highly audited. You cannot give it for more than even a day than what is prescribed. Steroids are extremely audited. So they have no scope of overusing. In fact, there are two physicians in the COVID care team who have to justify the use of initiation of oral steroids or intravenous steroids. 3 physicians have to justify the use of intravenous steroids in NHS situation. Whereas here, home care patients are receiving oral steroids without any monitoring. So I think that is the second. And the third is maybe, possibly, I'm not sure, maybe industrial oxygen has played some role, use of industrial oxygen, use of oxygen by patients at home. All these may have played a role. It might be multifactorial, but at the same time, 30-year-olds who have not received oxygen, who have just home cared themselves, are coming with mucormycosis. So what do we call that? Non-diabetics, So they may be the fourth channel which is directly related to the virus itself. So there are many things.
Yeah, thank you so much. Thank you. Thank you, Dr. Tote from Amravati, for putting the questions. So this OSWB webinar is being participated all over India as well. The next question is from Jorhat, Assam, by Dr. Polash.
Just for a reminder, many from Bangladesh also.
Yes. And I would request everyone to put their questions so that we can ask the eminent panelist as well. So the next question is from Jorhat, Assam, Dr. Polash Bora. He is asking, how long does it take to cure the mucormycosis in the eyes? There are some questions for ENT as well. We can ask them later, but let us ask Dr. Honavar, who is here at the moment.
Well, acute phase, if you intervene well surgically as well as with systemic therapy, that is amphotericin B, then the disease should be under control within 2 to 3 weeks. But that doesn't mean that the disease has been completely eradicated. There is something called clinical recovery. There is something called radiological recovery. Clinical recovery is monitored by endoscopy and also reculturing and repathology of the mucosal debris that can be harvested over a period of time, and also clinical resolution of ocular signs. Whereas radiological recovery is only when the radiological changes reverse on contrast enhanced MRI. Radiological recovery lags behind clinical recovery. So there is always a confusion that whether that small opacity that you see right at the cavernous sinus is active or not. We cannot ever be sure, because that is not something that can be clinically estimated. So it is always a good idea to continue treatment with amphotericin. Recommended is 4 weeks, but since it is toxic and expensive, at least 2 to 3 weeks, followed by oral posaconazole for 3 months to 6 months is the recommendation.
Thank you, sir. There is a question from Dr. Munmun Roy, again from Guwahati, Assam. What is the latest treatment protocol of the disease? So I think Dr. Honavar has enlightened us already. And next, Dr. Arjun Dasgupta will also touch upon. So that is being dealt with. The next question is from Dr. P.K. Singh from Kolkata. He is asking, at what time we can say the patient doesn't have any danger of catching mucormycosis post-COVID?
Well, right. Most of the cases have happened in the middle phase of active COVID infection. That is 1 week following testing positive. That is the beginning of the phase. peak has been seen between first week to third week following testing positive. And after that, there is a taper, and up to 6 weeks, there are cases that are seen directly relatable to COVID. But once in a while, we have seen patients beyond 6 weeks also. So 6 weeks is a reasonable cutoff. Beyond that, it is rare.
Thank you so much. And the last question before I hand over to Dr. Bhaduri to involve the panelists is from Berhampur, Orissa. Dr. Biswajit is asking, how long should amphotericin be given and the dose? You have already informed us, but if you can just repeat it once more, that will be very helpful.
5 milligram per kg body weight if the patient has orbital and paranasal sinus involvement. Once if it becomes a full-blown CNS involvement, then 10 milligram per kg body weight is recommended. Of course, it has to be moderated with high, very regular monitoring of the renal function, and the systemic status of the patient is also important. And it is to be continued as recommended in the guidelines of mucormycosis, at least for 4 weeks. But in the current situation where it has become scanty and very expensive and also toxic, 2 to 3 weeks is reasonable, but then it has to be followed up with a step-down therapy with oral posaconazole.
Thank you so much. Dr. Bhaduri, you can take up any other questions with Dr. Honavar and also with the panelists, please. You have to unmute yourself, Anirban.
Okay, so I wanted to ask our panelists, what has been your experience? Have you yet encountered patients?
I haven't actually in the last phase, neither I have seen any cases in this phase actually. Anirban, as you know, we keep on talking about what is the cause of this Bengali exceptionalism. But I don't think it will be prudent to rely on that. I think it'd be naive to expect this exceptionalism to last. This will probably disappear like, we are getting a surge in COVID cases. But I would like to ask a question to Santosh. Santosh, enchanting presentation as always. But, just to clear my doubt, I was under the impression that a nasal swab probably is not that effective because various types of mucorales are quite ubiquitous and the commensals also. So you may pick up spores from the nose, but nasal biopsy probably is a better way to get the fungal diagnosis.
You're absolutely right. Invasiveness has to be proven to have a complete diagnosis. But yes, in a situation where the patient has symptoms and signs, radiological signs, nasal swab is good enough to start on treatment, but confirmation has always to come on a biopsy or growth on 3 culture plates. Right? So, I mean, that process will take time, but here the time is the key.
Time is the key.
Right, time being the key. And these patients, for some reason, earlier also we used to see mucormycosis, 24 hours, it was okay to delay. But here, patient who comes in the morning at 9 o'clock, sent for a scan by 3 o'clock when he comes back with a contrast and his MRI, his disease is fully blown. So it's so rapid and it is growing so rapidly also. On culture plates, 24 hours, 18 hours, mucor is growing. That is unbelievable. There's something has happened to COVID as well as mucor itself.
I think eventually the fingers are pointing to our good old friend from 2019, our COVID friend. Right. I think it is doing something to your immune system and doing something to your receptibility to the fungal infection as well, probably. Time will tell.
Anirban, there are lots of questions coming in.
Lots of questions.
Almost 30-40 questions.
Sugato, we can take questions at the end of the
If Dr. Honavar is happy to stay back for few thank you so much.
I want to listen to your esteemed
there are lots of questions from all over India actually.
Absolutely.
Thank you. Anirban, if we can move on to the next presentations.
Professor Amitabh Raichodhuri is with us. Sir, Professor Rai Chaudhary is going to present a case. So what our ENT faculty have done is they've decided to do it in two parts. So Dr. Rai Chaudhary will be presenting a case, and Dr. Das Gupta is then going to talk about the management of the ENT problem. Dr. Rai Chaudhary, please. Amitabh,
not going to present a case, but I was going to discuss about diagnosis also. So we'll just quickly go through diagnosis, and my previous speaker has made a mesmerizing presentation and he has made my job very short now, but I'll still go through how ENT surgeons look at it. So I'll share my screen if you allow.
Yes.
At the outset, I'd like to thank the Ophthalmological Society of West Bengal for having involved me for this important thing. And this is more important to sensitize our colleagues today, ENT fraternity, oral and maxillofacial, dental, ophthalmic, everyone, that this is an emergency which is going to be faced by us in West Bengal also very soon. I mean, we can't avoid it. So again, I have no conflict of interest to declare. I think this has been partly told by him. I'll not waste much time because I gathered that there's a lot of questions coming, but this is from Mucormycosis families, and the commonest organism is Rhizopas. Again, I think this has been well covered by previous speaker, so I would not go into it. But I would just again highlight that the importance, because this is a webinar where we are trying to sensitize ourselves about why this is happening and what we should do and how well we are prepared, so that we are not in a situation like Indian healthcare system where we are not able to cope with the load in case the load comes to us in West Bengal also. So there's only one thing which I was reading somewhere, that whether this COVID infection itself has some effect on the insulin metabolism, and insulin regulation has been becomes disturbed, because there are some papers which are evolving, and that may actually aggravate the status of diabetes control, glycemic control in some patients, and people who are non-diabetic may have been rendered diabetic or may have been rendered hyperglycemic after use of steroid. So there is an element of that. And rest of the things, and one more point that I want to highlight here, that it is documented that there's a lot of endothelial damage from this infection, and therefore this is one of the reasons which maybe the surge. This is just to add to what my previous speaker said, that because the endothelium, vascular endothelium is damaged, this is documented, and therefore this is a disease where angio invasion is the key, which is the main cause of rapid destruction of tissues, and therefore this is another reason. And there's one more small things that it came to my notice, that people are talking about this rapid increase in contaminated water in oxygen concentrators because of unpreparedness of our healthcare system, which may be a cause also of increasing changing of nasal flora, and thereby an immunocompromised patient may harbor or may get this thing. These are the three things that I would like to add to what you said. Now the question is, why are we so concerned about this? Firstly, it is angioinvasive, because this is a disease which goes and just taps the blood vessel, and through the blood vessel it causes end arteritis kind of situation, and therefore it's most of the time, if we are delayed, it's a lost battle. We can't do anything because there are too many vital structures gone already. Secondly, it's a tissue destructive, as I said. Thirdly, it does not have any boundaries. Any other disease like cancer or any other infection usually follow some pathway, have some barriers. They take some time to go to the, breach the barriers. But here there is no boundary at all because of the vascular angio invasion. And there are so many vital structures vulnerable here, in addition to the orbit, which he talked about. And I think he's already talked about the mortality rate. So the key here is that we have to detect them early. If we catch them early, we will be able to deal with this problem. Otherwise, one more point which I think needs to be discussed at our level today is that medical treatment, because it's a toxic drug, and I have had few patients earlier, not in COVID, where the patients, we could not continue the treatment because of, even with a liposomal M4B, we could not continue because of the nephrotoxic effects or other toxic effects on the body. So, and expensive is an issue, availability is an issue. So we not only need to sensitize ourselves today, we also need to sensitize our government that these drugs should be available in our state also, should we really face an epidemic. Because otherwise it'll be again like the oxygen story. We'll not get the drug when we get too many patients together. So this also has been highlighted by him, the stages. So if we pick them earlier, then our treatment outcome is likely to be better. We have been following in the earlier days, this is a very old staging system in 1991, and we have been following this. Stage 1 is nose and sinus, stage 2 is orbital, and stage 3 is like cerebral, which I think my previous speaker has shown nicely a newer classification, which also is fine. It is not the stage which is important. The point is that if we can catch this patient in the first stage, when the disease is nose and sinus is contained, I think we can cure them. If it has gone beyond the nose, orbit, still manageable. If it has gone beyond the orbit into the cranium, then it is extremely difficult. Now, why does it happen so rapidly? Because nose has a blood supply of a mixture of internal and external carotid system, and it's an extremely vascular system, and that is why this area, actually, the moment the fungus gets harbored pathogens here, then immediately, because of the high vascularity, it tends to spread to all areas. And as we know, this is a lateral wall of the nose, where we can see the sphenopalatine artery is the main artery, and then we have also branches from the ophthalmic artery. So eyes and nose have a little bit of combination, and in spite of that, we have so much problem. And this is the ophthalmic artery, which is a branch of internal carotid artery. So this is the reason that there is so much of rapid progression of this disease. I think presentation, as far as I am concerned, ENT is concerned, most of the patients will initially present with yellowish and blood-tinged discharge. Given the history of a patient profile, we must suspect from this stage what is happening. We should not, many a times, today we are talking about COVID mucor. We have seen many mucor patients. I think all of you in the panel will agree with me that by the time the patient reaches the clinician who is able to deal with this problem, it is too late. Too many days has been spent on patient going for a scan, getting some antibiotic for sinusitis. That is what happens because we do not think about this disease so well. Now we have to, because it is an impending epidemic in our state, and rapidly it turns blackish, yellow, and eventually dried up secretion. Why dried up? Because by that time the necrosis would have happened, and there is not much of nasal mucociliary clearance, and there is no secretion, and that is also an alarming sign. Then it started with a yellowish discharge, and finally became blackish and bloodstained, and finally dried up. So that raises the first suspicion. Patient profile has been discussed thoroughly by earlier also. Now, fever and pain sometimes mimics cold, but my previous speaker again very categorically highlight that if we have a cold, if we have sinusitis, which is the common mistake that people do, treat the patient as sinusitis from ENT point of view, then the cold will the pain, facial pain will not resolve if it's a mucor. it will continue to rise despite having a paracetamol and antibiotic. And numbness around the nose and cheek, that is the most important thing. Once this starts, we know the infraorbital nerve has been affected, which means a sinusitis, acute sinusitis will not cause infraorbital nerve damage, infraorbital nerve involvement, and numbness will not happen. And that rings our first bell. So normally that will ring the first bell. Then we can also have toothache, ill-fitting denture, which is neglected, but most of the ENT people and maxillofacial people know that people sometimes, even for cancer, they complain the only presenting symptom of destruction of palate can be an ill-fitting denture. I know this is a very drastic situation, but it can still happen in 2-3 days time, and we have had patients like that. And last is blackish discoloration of the cheek or palate. The moment we see this, and I think multiple bells should ring, and you must get the patient on board, and we must immediately, start a multidisciplinary treatment. What I think Dr. said just now. So that is important to have a high index of suspicion. So this is a picture of a typical kind of necrotic palate. The palate is necrose and there is a little bit of blackish area. And as the doctor was saying, that when we take a sample, we should take sample broth from scraping from here, and also the biopsy must be taken from margin also. That is a very important factor. And this is the entire palate is gone here. And this may look sometimes like an aspergillosis, but not at all. This is a totally necrotic palate. So this is another very alarming sign that disease has progressed beyond the nose and sinuses. It has now come to the palate. It has destroyed the palate. The fact that it has destroyed the palate, it is bound to have destroyed the orbital fissures and all the crevices of the orbit. This is the blackish discoloration, which again should, as I said, should ring multiple bells. This is one of our patients where we saw that the patient, as you can see, presented with proptosis and sinusitis-like symptom. Unfortunately, this patient was treated at various places with antibiotic for 2 weeks. And by the time the patient came to us, this was the picture. And I think nobody should think that this is a sinusitis complication. This is obviously a mucor. And unfortunately, this patient, by the time we started treatment and planned for a debridement, the patient succumbed because it was too delayed. So that is the message that I want to give, that slightest suspicion, you must start the treatment. And I think this has been described by my colleague, proptosis, ptosis, facial swelling, loss of vision, all these things have. Now, finally, when it goes beyond orbital stage, pain sometimes becomes less because all the nerves are gone, all the nerves have been affected, and multiple cranial nerve palsy happens all of a sudden drastically over a matter of few hours, and patient gets cavernous sinus thrombosis and delirium, and finally sometimes succumbs. This is another patient. This I have already described to you. This is another patient which presented to us in a very, not in COVID era, in a very, what I want to say that sometimes the patient may present in not a classical manner. This patient present with a proptosis, with a ptosis and a little bit of nasal discharge for quite some time, according to him, a couple of weeks. Scan did show things, and immediately histopathology was done, and we could do a full sinus exenteration, and even the orbital exenteration has to be done as judged by the ophthalmologist. We did the procedure together, put the patient on amphotericin B, and the patient developed acute renal failure. Even liposomal did not help. But however, with great difficulty, we managed to treat the patient for 2 weeks of ampho B, and the patient then was discharged on posaconazole, and subsequently patient was lost to follow-up. We did not know. Patient came to us after 3 months. Up till 3 months he was fine after orbital exenteration and sinus surgery. But yesterday I wanted to find the records and the scans of the patient. I called the family and I found out that he is no more. And he did not come back to us. He went somewhere else when he had some episode where I do not know what happened. So again, initial recovery and staying good for 3 months always does not mean, I do not exactly know how he ended up, but apparently he had some pain in the head and he had finished. This is another patient. Again, you can make out that there is some ophthalmoplegia situation. When we did scan, otherwise he does not look very toxic. History was a little bit longer. Diabetic patient, uncontrolled, poorly controlled diabetic. Again, showed signs of mucor, and immediately we could diagnose. We could do a wide exenteration of the sinuses and orbital, because there was no devitalized tissue in the orbit. Orbital management, no surgical management needed. His eye was saved, but vision was lost anyway. So, but then this is quite a few years ago, and he's been coming for follow-up and he's doing well. But we should not confuse this with our usual preseptal cellulitis. So what, I mean, this is, had it been a ENT forum, I would have said that probably, I think in an ophthalmologist forum, I should not tell that this is a simple preseptal cellulitis, which is also a complication of acute sinusitis and sometimes needs a very urgent scanning and visual checkup and all that. So the diagnosis based on nasal endoscopy, CT scan, contrast MRI, local tissue scraping for fungal stain, biopsy as has been described, and some inflammatory markers. So this is a nasal endoscopy, just quick endoscopy to see. This is the earliest form of finding that you can get in the nose. That is the middle turbinate, as you can see, which is just black discoloration. There is still nasal cavity, is still vascular, and this is the earliest sign that you can see in the nose. And ideally, you should take a scraping from here and take a biopsy from here, and most of the time you will get a positive diagnosis. This is an advanced case where the nasal endoscopy, as you can see, as if somebody has burnt the nose inside. It is totally charred. There is no structures visible. This is a classical mucor again. And moment you see this kind of features, you are 100% sure that this is mucor. But yes, for starting such a toxic treatment, one must get mycological diagnosis and histopathology. But we should never wait for a histopathology. At least we should start our debridement. We should do the surgical management. So nasal endoscopy is very bedside. It can be even done bedside if the patient is moribund. Important thing is that instead of taking a swab, we believe if we can do a nasal endoscopy, we take a biopsy. And if there is things like what I showed you in the palate, that you can take a scraping from those necrotic tissue also, that will also usually grow. On stain, on KOH mount will grow the mucor. But the important thing is that we cannot wait for histopathology to start our treatment. Frozen section, if it is available, it's a very good option, because if you take a frozen section biopsy, you get the result in 30 minutes, your results are confirmed. You start the treatment as well as you start your extensive radical debridement, whatever is necessary. But this should not be confused. Again, this is for more or less for our ENT colleagues, that we often do a lot of sinus disease in ENT, and these are the kind of sinus fungal debris, mostly from Aspergilla, Alternaria, all those sinus, where all those funguses that we get, and that is totally different color. The nasal mucosa bleeds profusely, which is not devitalized, and the color of this material is also different. So this is a differential diagnosis that these are non-invasive form of sinusitis, which we are very commonly dealing with nowadays. And I'm sure after COVID, this will increase again. And mycology again shows that the differentiation between two things, I think basic difference between the Aspergillus and the mucor, which is common, is Aspergillus is septate hyphae, which is like you can see septation here, and septations are at acute angle, and these are non-septate hyphae, and branching is at 90° and very thick and stubborn, wide kind of hyphae. That is mucor. Now, CT scan does have a role definitely in initial diagnosis, and it also helps surgeon to have a roadmap, because here in this CT scan, as you can see, it is bilateral involvement already. The frontal sinus, it has gone up to the frontal sinus. There is a little bit of breach in the posterior table of the sinus. On your left hand side, as you can see on the left hand side of this screen, you can see that there is a orbital penetration and there's a lot of bone destruction. So CT scan does help, but the gold standard is MRI, as has been highlighted by previous speaker. It has to be gadolinium contrast enhanced, and it has to be multiplanar, and ideally a fat suppression technique so that you can see the other structures better. And it should involve orbit, paranasal sinus, and skull base, everything. Because if you just prescribe, I'm talking all these things because we all tend to see patients and suddenly prescribe MRI of the paranasal sinuses, MRI of the orbit, just because there is an orbit problem. So moment we see this kind of thing, the entire region has to be mapped properly with a contrast enhanced MRI. So it shows the entire disease extent. Why is MRI superior? And it can differentiate between a non-vitalized and vascularized tissue. The tissue which is already necrosed, that needs to come out in surgery, and tissue which is vascularized will respond to amphotericin B, will have to be differentiated, and that is where the role of MRI is very vital. And if invasion of great vessel is suspected, then obviously MR angiogram should also be added to this, which is, I know, maybe a constraint in many of our healthcare system in this part of the country, but we have to do this when we see a patient like this. And if we have the slightest doubt of any cerebral involvement, then we must also add a diffusion weighted MRI of the brain, because then that will even pick up slightest brain involvement, because otherwise if you're doing a very extensive debridement to a patient, extensive surgery, and because of that the patient may not survive, patient may not do well. So prognosis is important, and that is how we will proceed with an MRI. So I think he has shown us multiple scan. I'm not going to describe. Here you can see the MRI where you can see the disease into the orbit, it has gone. Again, a CT scan where you can see the disease in the ethmoid sinus, maxillary sinus, and the orbits are fine here, but there is a little bit of orbital penetration which is confirmed by the MRI in the same patient. This is a T1 and this is T2 MRI. In the lower part of the MRI is T2. In the T2 you can actually see better, but in a T1 you can see the fat signal void if there is a fungal collection. If there is a tissue destruction, then you will see a different picture. So this is another MRI where you can see the left side, where left marked, you can see the middle turbinate is very highly enhanced, and also there is orbital involvement in this MRI. And same patient, another cut where you can see the orbital involvement is there. So the question is, how does it spread? Apart from why does it spread so rapidly? In spite of the in spite of the treatment and in spite of the debridement, it keeps on spreading, because from the nose it goes to the pterygopalatine fossa, which is a place behind the maxillary sinus. From there it can go to the orbit through inferior orbital fissure. This is a faster route through the natural crevices, in addition to the angio invasion route. And cranium through foramen rotundum from the trachea. I'll just show you a skull image. And then from the nose, it goes to the ethmoid sinus, which is the commonest sinus involved in these cases, fungal infection and mucor. And from the ethmoid sinus through breach of lamina papyracea, it will go to the orbit directly. So direct orbit, orbital extension in the anterior part of the globe through the ethmoid sinus, from the pterygopalatine fossa through the inferior orbital fissure into the orbit, which is the posterior part of the globe, and it can go to the cribriform plate and perforate and destroy and go to the cranium. So these are the routes, and this is an image to show. This is a lateral image where you can see this is the maxillary sinus, this is the nose nasal bone, as you can appreciate. This is the back wall of the maxillary sinus, and this is a bone called pterygoid process. So this is called pterygopalatine fossa. Now from the nose, first it goes to this area, and from here it can go through foramen rotundum to the middle cranial fossa, through the inferior orbital fissure into the orbit, and all the other areas to the infratemporal fossa, cheek, everything. So this is the area when we as a surgeon explore, we have to explore, and from there we identify the dead necrotic tissue. Wherever it is going, we have to keep going. And this is the cranium showing the cribriform plate route. So prognosis, I think it has been discussed. I am talking about a different staging system, so I'll skip this slide. So who should be screened? First, the patient who is at discharge having lymphopenia and neutropenia after COVID-19, diabetes uncontrolled, high dose and early initiation of steroids, and obviously immunomodulator therapy, which is very risky for this patient to get this mucor because the immunomodulation is already done. High ferritin, because somehow mucor is known to have a little bit of affinity for ferritin, and therefore if the ferritin level is high, then the chances of mucor getting is higher. Prolonged ventilation has been already highlighted, and prolonged use of antibiotic in case of ITU stay and secondary infection can also make a person more prone to COVID. And I will not go into the domain of management, but just our philosophy is that obviously immediate aggressive treatment, multidisciplinary care has been highlighted. Now, wide radical debridement can be either open, like you can open up the maxilla and do everything from there, or you can do an endoscopy depending on the surgeon's level of training, level of choice. But debride every bit of devitalized tissue, which I'm sure our next speaker will tell you. And the main principle is that keep on debriding dead tissues, devitalized tissue, till it bleeds profusely. Then we know we have reached. So the dead tissue will not respond to amphotericin B, but live tissue will respond to M4B. That is the principle. So if we remove the load of the necrotic tissue, then the medical treatment will work better. And here, obviously, life saving is priority. Sometimes organ preservation may not be a priority. And I think repeated debridement will be required. And this, I just want to finish by saying that this is a multidisciplinary team that we all need to have ready now, because we are going to have this soon. ENTI is the main pilot seat. Radiologist is the main backbone, and internist and intensivist, they are the main backbone of treatment. And obviously microbiologist, mycologist, pathologist, dental, oral and maxillofacial surgeon. Everyone together, hopefully together, we will be able to deal and tame this wild horse that we have called this presentation today. So we are fighting an unknown disease today, COVID-19, which is very true. But mucormycosis is a known disease to us. There is no reason why we cannot find this. Only thing, the intensity, the drasticity, the frequency, the number, the volume will increase. We will have to deal with them. I'm sure we will be able to deal with them with the teamwork. And only thing we need to do is to need our Antony on very high alert, because the eyes cannot see what the mind doesn't know. Thank you very much for giving me an opportunity to share my thoughts.
Dr. Rai Chaudhary, thank you for a very comprehensive coverage of the ENT aspect, something that we as ophthalmologists often ignore. And you have very rightly emphasized the need for a multidisciplinary approach. Thank you very much, sir. Dr. Dash Gupta, if you would please start.
Anirban, just one thing, we have almost 40 questions. So, so far.
You want to take questions now?
No, after finish.
After Dr. Dash.
Question once Arjun finishes probably here.
Yeah.
I will try to be quick. Thank you, all the speakers before me, and Amitabh, who has explained very extensively what Mucor does, and especially in the COVID situation. So I'm not going to go into the details. In fact, I may skip a few slides because I didn't know whether they will cover it or not. I just wanted to give you a view about what the ENT surgeons we do, because we do deal with these kind of surgeries on a day-to-day basis, which we commonly call as endoscopic skull-base surgery. So basically, it's a very aggressive surgeries that we have to deal with the sinuses and around it. And in this Mucor, especially the surgical debridement is one of the key to controlling, along with the liposomal amphotericin B. I think it has been enough specified. So I'm going to skip these two slides, which is going to tell you just one thing. I'm going to tell you is the nasal and the sinus wall are invaded by the vessels, and it is a thrombus formation. So there is a breakdown of bones, and there is a lot of devitalized tissue. Now the whole question is, how much should we debride? How much should be debride is already told by our previous speakers. Is one of the main guidance to what we will debride is determined by an MRI, especially the contrast MRI. So the contrast MRI, the basic principle is very simple. If the contrast has perfused in those tissues, then amphotericin B is also going to go there. So please don't bother about excising everything. So the contrast areas where the contrast has taken up, you may think that to spare those areas and wait, it may need multiple surgeries. You need to talk to the patients and the patient's family about it. I just read a case report where one person had 28 surgeries, and many of them can be just debridement. It can be toileting, and there is a role for local amphotericin B. People from Maharashtra who has already reporting Mucor from the first wave last year said that some gauze impregnated with amphotericin B can left into the sinus cavity, especially in the orbital apex area, and they can deal with it. So don't just take everything off in the first go. You can do it again. And one of the cornerstone is the orbital extenteration. There were the ophthalmology colleagues coming to great help, whether the person will need an orbital extenteration or not, because that's one of the most difficult decisions to take during the surgery. I'm sure you guys will, some of you will know better it than me. So I'm just going to go into details about the endoscopy. I'm an endoscopic surgeon, so I'm obviously you need to have knowledge about the open approach as well, because that will help you. So this is where the aperture, piriform aperture is, and this is where the endoscope goes in and goes into the sinuses. And as you can see that it is already quite restricted, view of the sinuses in here, and the endoscope maneuverability. So one of the things to do is to increase this aperture, and if we take this bone away, which we call the endoscopic modified dentures, then we can reach each and every part of the sinuses. Say if you look at this, if say in this area, if you put an endoscope through this small aperture in here, you want to reach the posterior wall of the maxilla, or in the pterygoid foramen, or the retromaxillary area, or the sphenoid. You can reach, and you need a little bit, you need to take this bit of bone away. So this is how we work. So basically, we start with a middle meatal antrostomy, which is we make the antrostomy bigger. We do a mega antrostomy. We do a modified endoscopic medial maxillectomy. We try to take the medial wall away. Then we do a total endoscopic medial maxillectomy. And even if that doesn't work, we go through the other side of the nose, make a hole into the septum, and we go through there because we need to move our endoscope from one degree to another. We can even dislocate the septum dislocation and endoscopic dentures. We can go below the lips through a Calderon or sublabial approach. We can do an open approach like midfacial degrubbing. And last, if nothing works, we can always do a lateral rhinotomy surgery in there. So this is what I'm talking about. This is the inferior turbinate. So if I want to go to a lesion which is very lateral, we need to take this bone away. Otherwise, we won't be able to maneuver our endoscope. So we may have to remove the inferior turbinate and this whole area to reach to the posterior, very difficult to reach areas. So this is the one of the cornerstones how we start with, which is called the endoscopic modified Denker's approach, which is what I already described. We take the anterior wall of the maxilla, we drill a hole into it, and that makes our job much more easier. So this is what it is. This is, say, it is the inferior turbinate, this is the middle turbinate, and you make an incision over there, and you strip the mucosa and the skin away from there, and you make a hole in there. This is the anterior wall of the maxilla, and behind this is a maxillary sinus, and you can drill a hole in there, and you can directly reach the maxillary sinus. Then you can take this whole thing away, and whole thing becomes a cavity, and it makes our job much more easier. This is what the incision is. They have lifted the flap away from, this is the anterior wall of the maxilla, and this is they have made a hole in there. This is the maxillary cavity, and at the end, this is what it looks like. This is the maxillary cavity, this is the nasal cavity, this is the sphenoid, there is the orbit, and this is the nasopharynx. So whole things become one, and this is the amount of job we can do already. So this is the endoscopic modified Denker's already. This is what I have explained. You can take the endoscope, and if you take this piriform aperture, if you take this bone away, you can reach very difficult position, which is not possible for the endoscope to reach. And you can also make a small hole into the septum, transseptal approach, and you can reach those areas as well. So this is again showing the same thing, the anterior maxillary approach. The next thing we come to about is the ethmoidectomy and to do a medial orbital decompression. Now, there is a lot of ophthalmologists here, so we can reach the orbit through the medial wall. What we can do is if there is a limited involvement of the orbit, we can do a debridement through the endoscope through the medial wall. So how it is done? It is done through 5 steps. So identification of the sphenoid ostium and anterior sphenoid sinuses. So you need to understand where the sphenoid sinus is opening, and you draw a line over there. You need to open it up, and that will work as a guide to further. So this is a sphenoid sinus, and you can see this is the optic nerve in the lateral wall of the sphenoid sinuses. This is the first step. And you make the sphenoidal opening bigger, and then you identify the maxillary ostium, which is in front, and do a wide millimeter antrostomy, very wide. So that's the next part. So this is what I have shown you already. This is the middle turbinate, this is the inferior turbinate, and you do a very wide millimeter antrostomy in there. And then anterior and posterior ethmoidectomy, as Dr. Amitabh has already mentioned, these are the most common sinuses. Those are involved with mucor. So you take the anterior and the posterior ethmoid out. So this is the sphenoid, this is the anterior and posterior ethmoid, and this is the bulge of the orbit. And you slowly clear out all the ethmoidal bones from there. And third is the removal of the lamina papyracea. I don't have to explain to you. It's called papyracea because it's paper thin. You just have to break it and take it piece by piece. So only the periorbital remains and the lamina papyracea is removed. So this is how we do it. We remove it, we scoop it, and you can see already the orbit is bulging. If you're in doubt, you can press the eyeball and you can see the movement in there. And lastly, you remove all the bones over there and do a wide orbital decompression. And lastly, you do a longitudinal incision of the periorbital sac, and let the fat prolapse from there. After you, just one thing is you need to again be guided by the MRI and your ophthalmology colleague how much to debride, because the orbital fat, if it is necrose, you remove them. If there are muscle involved, you can do them, but be very careful and be guided by your ophthalmology colleagues. But obviously, orbital exenteration and anything beyond that, you need your ophthalmology colleagues inside there, because it's medically is also important. You need them in the theater along with you. So third thing is the frontal sinuses. The frontal sinuses we call is a draft procedure. You can do it in 3 stages. So draft 1, draft 2, and draft 3. So this is the draft 1. This is the anterior-ethmoidal cell, unsealed process, obstructing frontal sinuses. So you clear it off. You can see that you can go straight into the frontal sinus, and all of these cells are cleared off. And this is draft 2. Draft 2 is a little bit more in the floor of the frontal sinus. You drill and the lamina papyracea to the septum and anterior fascia of the frontal sinus as well. So this is a sagittal section, and you drill this bone away as well. So this is slightly bigger. Draft 2 is between draft 1 and draft 3. And draft 3, you take the interfrontal septum away. So the septum that divides between you can actually approach and clean all those frontal sinus materials, all the ethmoids, everything through a draft 3 approach. And I think in a mucor, if it is involved the frontal sinus, we should be prepared to do a draft 3 if necessary. This is the pterygoid bone, and this is the sphenoid sinuses. This pterygoid bone is very important, as Dr. Amitabh was already mentioning. It's because of the vascular structure. And if that is involved, the greater wing of sphenoid and the pterygoid, if they are involved, if you don't remove them, then you probably haven't done the job. And that's one of the most difficult things to remove. We can reach, this is a cadaver dissection, we can do through if we remove this bone and do a modified Denkers, we can reach right up to the posterior pterygoid area. And this is again a cadaver dissection where it has been done. And any lesion in those areas, even the retromaxillary area.
One second, Dr. Arjun, please cut short your presentation. We have a lot of questions, almost 50 questions.
Okay. I will just show a small video then.
That will be the relevant for our ophthalmologists also.
This is something called a coblation, which you have seen working. I'm sure Amitabh Roy Chaudhary doesn't remember it. This is a case from our last AOICon, and this is a leftover case, and it was myself and Dr. Amitabh Roy Chaudhary operating on it. It came back as adenocarcinoma, but this is retromaxillary in the pterygoid area, so that's why I thought this video will be relevant to show where exactly it is reached. The time is running out, so I will just skip. This is where we are clipping the maxillary artery. This is actually, we have taken the posterior wall of the maxilla and we have gone right to the retromaxillary area. And I will try to be as quick as possible. So this is the last bit of it coming out. I just wanted you to show the cavity. If you can just spare me a minute. Yeah. So this is the lesion, and if when I go in, I will try to freeze a minute. Sorry. I missed it. Yeah, the same area. Sorry, I'm messing it up again and again. So basically, this is the pterygoid area. We have taken the pterygoid bone away. This is some of the orbital fat prolapsing. This is the posterior wall of the maxilla we have drilled. This is the sphenoid sinuses. This is the nasopharynx, and this is the maxillary cavity. And you can see these are the areas where we can reach. It's not that difficult. The bleeding is not an issue, and you can see the maxillary cavity on the left hand side. This is the sphenoid sinus, and this is the retromaxillary area. This is just to give you a flavor of what we can do, how extensive we can be. Thank you very much. And lastly, it's just teamwork. Everybody, the anesthetists, the surgeons, the nurses, the technicians, we all have to work together to fight these villains. Thank you very much.
Thank you, Dr. Dashgupta, for your coverage. My question is, can we work together in the sense that can you have a combined team doing the exenteration as well as the sinus debridement at the same time?
I'm sure we can. Why can't? Actually, the ENT surgeon cannot do orbital exenteration. We need the ophthalmological surgeon. And if there is an indication, whether it needs orbital exenteration, we need a permission from the orbital surgeons to tell us whether it needs orbital exenteration. And if it needs to be done, we will do the sinuses. And I think you should come and do the orbital exenteration along with us, so we can combine these both together and finish the job.
Anirban.
Ghosh.
Yeah.
Ghosh.
Yes.
Is Dr. Tusharkanti Ghosh there?
Yes, sir.
Sir, is there anything else you would like to add from the ENT perspective?
Now, already Dr. Aisudrian Zunda already told everything, but main basic is the basically combination of the ophthalmologist and ENT surgeon. Basically, we should remove the devitalized tissue to reach the amphotericin B work. Basically, the multidisciplinary approach. So our work to remove the all dead tissue, removal of the all dead tissue. So we are more comfortable nowadays through endoscopic route up to the medial part of the orbit, all up to sinus, cavity, and pterygoid, all posterior part of the maxilla, all will be possible through endoscopy. Definitely, sometimes external approach required, but it's possible to remove all defective tissue removal, because if not removed, if we apply the amphotericin buoy, it not work, and it will it should give prolonged days. So if we remove the defective tissue, so amphotericin B required less days, and it will cure easily.
Thank you. That was a very nice point made.
Anirban, Sugato, please. Sugato,
Would you like to continue with the questions?
Yeah.
We have lots and lots of questions. I would request all the faculty and the panelists to stay with us. Several of these questions have been answered during the course of the lectures.
Yes.
Dr. Devashish Das.
Saurabh, you wanted to ask something, Dr. Saurabh Sannal.
Yeah, actually, what my point is that after listening to this extensive detail of mucormycosis, for a general ophthalmologist who is practicing in the remote localities of different places in West Bengal, what should he do first? That is the first question. I diagnose a case in my clinic of orbital mucormycosis. Now, what should be next approach?
Suspected mucormycosis.
Yes, suspected.
Yeah.
And as described by everybody, this is going to come up because everywhere the COVID is now there. All the district hospitals, they have a COVID ward now. So what shall I do? Whom to send? The first thing, and what medication should I start? Is there anything I can do?
Dr.
If I cannot, then what should be the chain of reference? Can we form a team of ENT, internist, and an ophthalmologist in both private and a medical college? Otherwise, all these patients will not be able to afford in my private setup.
I think you're absolutely right. You're absolutely right. You're in the beginning of the curve, and you can learn from the rest of the country's disaster. In Maharashtra, it came as a big shock, and Gujarat, it came as a big shock. You have to proactively form teams right now. Maybe Bengalis are immune to it, I don't know. But you have to form teams right now even at the level of districts, there has to be a mucormycosis care team, because these patients cannot be transported longer distances. They are already morbid. So government and private setup, you have to have very, very nice teams already, complete team, including an ENT, ophthalmologist, oculoplasty surgeon, microbiologist, pathologist, radiologist, everybody put together, intensivist. Then make those teams and give that contact number or the team coordinator information, spread it all around, and whenever somebody encounters such a case, they should immediately refer such a patient to the nearest team.
Thank you, Dr. Honavar. On behalf of OSWB, we'll definitely take up this issue to our managing committee to immediately make a nodal group for every district and SOS group and a referral group for this patient to the city or wherever it is possible to treat this patient. Dr. Rajesh Mojumdar Chaudhary already make a group for this mucormycosis. Rajesh sir, can you highlight please what are you doing in this group basically?
Yeah, okay.
Are you sensitizing everyone to this problem is coming up, or are you sensitizing everyone?
Presently, we are sharing information only, right?
Yes, we are sharing information, and we are trying to make this group as inclusive and as expanded as possible. We have included pulmonologists, oculoplasty surgeons, ENT surgeons, and intensivists as well, and radiologists. Plan is to basically act as a bellwether, act as a the first canary in the mine, as it were, so that in case there is a proper case which is confirmed, we can share that amongst us, and rest of us can follow that case, and we prepare ourselves that these things will happen, obviously, for all of us. So that is the main purpose. But I think the focus of the group still has remained very narrow, in the sense that it's a city-based group. We have to expand this to all the districts of the state.
Dr. Joyita Das, please, yes, do you see any case of mucormycosis or suspect in our OPD?
No, till date, fortunately, I have not seen a single case of mucormycosis.
But or the Disha Durgapur
branch in these different branches, they have already encountered and referred them to ENT surgeons.
Almost 4 cases, I think, so far.
But are they confirmed, Arup? Are they histopathologically confirmed?
Yeah, they are now at the domain of Mission ENT department of Mission Hospital. I'll inform you, let you know that.
Could you kindly let us know what is happening with those cases eventually?
Exactly.
There is a question from Dr. Devashish Das to Dr. Honavar sir. Why this disease was not noted that much during the first wave, and why we are noting this during the second wave? Is it because of extensive use of steroid during the second wave, or something else?
That could be one of the reasons. Extensive use of steroids, and tocilizumab was never used in the first wave, not so extensively. Towards the end of it, it was used. That is being used now, indiscriminate use of steroids. And there seems to be a mutation in the virus itself that is rendering nasal mucosal immunity to almost none. And that could be one of the reasons. So it is multifactorial, and use of industrial oxygen, long hospitalization, all that is. And then this particular wave of COVID has been more diabetogenic, I believe, that is what the intensivists say, than the earlier wave of COVID. So this strain has a higher preponderance to affect the islet cells of Langerhans. So whatever may be the reason, it's multifactorial. And one more thing I wanted to say was that you should sensitize your government channels to stock up at least or ensure supply of amphotericin. Amphotericin is made in India. It's not an imported drug. But these drug companies which used to make amphotericin used to make it in limited quantity because it was a rarely used drug. It was not a very commonly used. They have redundant capacity, and they should just augment it.
That is a very important suggestion.
I heard always it is already out of stock, I think.
It is
already.
Yes, sir. Even voriconazole, posiconazole also out of stock. Today also I faced the same thing.
Black marketeers, they are stocking it and then they're not selling.
Can I just add one thing? In the first wave, our colleagues from Maharashtra and the Gujarat, these states, were reporting mucor, and we were discussing among ourselves what happened to us and why they are having so many mucos while we are not. But this wave, it has reached us. It has reached. I already got one case. Unfortunately, the patient died. There is another patient on the way coming from the district. Will reach tomorrow morning. So it has reached our shore, and it's trying to put our defenses up.
So, thank you. So, next question.
Sir, I have. Sorry.
Yeah, yeah.
Sir, I have one question, sir. Sir, can you incorporate routine endoscopy in all the post-recovery COVID cases, like in their first follow-up, second follow-up, like by the?
We are requesting all the people who are suspected of COVID from whichever the critical care or recovered COVID, diabetic, immunocompromised, any with nasal stuffiness and things to be referred for routine endoscopy, because the early COVID changes can be picked up by nasal endoscopy. And nasal endoscopy is, thanks to our neighboring country, manufacturing of cheap endoscope, everybody has an endoscope, even in district villages. And that's answer to the Saurabhs and as well. Everybody in the districts, the young ENT surgeons do have very good endoscopes. They can pick up COVID very early because they need to, and they can do the needful. So refer at the earliest, and not only one referral, they need multiple follow-up referrals as well. So first,
so how long we need to follow them up, like after COVID recovery, like 2 months, 3 months, 6 months, how long we should do it?
I think Dr. Santosh wants to answer that.
No, that's, I mean, recovery, after recovery, 6 weeks is reasonable, but even after 3 months, we have seen cases. But what I would say is that, the incidence is not so high. Numbers are overwhelming because we have never seen such a tsunami of mucormycosis earlier. But if you look at the overall number of even the second wave, the incidence is less than 1%. From whatever number of cases I could put together in Maharashtra, having spoken to groups, and Gujarat, incidence is about 1%. So to diagnose one patient, you have to do 99x nasal endoscopy and multiple times. So that is going to overwhelm, I suppose, the medical fraternity doing nasal endoscopy.
I think there should be some checks and balances. Right. The checks are basically diabetic, immunocompromised, oxygen therapy, and any. I mean, when I was speaking to my pulmonology colleagues, they said that which one the cases you suspect. They said the patient who have a nasal stuffiness, who are bleeding, and he said that all of them bleeds because we put them on anticoagulant. So it's a difficult time, but obviously we have to understand the mortality of this disease is 70% and up. And in a very early, if we just see the middle turbinate involvement and we excise it and give a liposomal amphotericin B, these patients can be saved. So maybe, and we are not, ENT surgeons are, what can I say, not that busy in this pandemic. So we would like a little bit of extra work if you don't mind. Thank you.
So the next question is a very important question from Dr. Nayak from Cuttack, Odisha. If the clinical findings and radiology suggest towards mucormycosis, can amphotericin B be started before any microbiological opinion? So what he is suggesting is, if the radiology and clinical findings are suggestive and we are yet to receive microbiological confirmation, can amphotericin B be started? This is a question from Dr. Nayak, Cuttack, Odisha.
I don't think we should start amphotericin just based on clinico-radiological correlation, because there are many simulating diseases. In fact, chronic sinusitis, for example, aspergillosis can look the same. So we have to have microbiology correlation. A smear or a wet mount, KOH, calculfluoride is all that is required to get a microbiology correlation.
Thank you, sir. There is another question from Haldia. Dr. Bidhan Roy is asking, is for all the faculties who are seeing the patients, what is the median presentation time from the onset of symptoms you are seeing? Median presentation time when the patients are presenting after the onset of symptoms. Are they
presenting to the clinician?
Okay, 3 to 4 days.
3 to 4 days. And is it too late to be presented?
Yes, the 3 to 4 days is late because the evolution of this particular crop of COVID-related mucormycosis is very rapid, more rapid than the cases that used to be seen earlier. So it would have passed the rhinal stage sinusal stage and then gone to the orbit stage by 3 days or even intracranial. So I think earlier presentation would be better.
So it is very essential to get the radiological and the microbiological confirmation as early as possible.
As soon as possible. In fact, learning from Maharashtra lesson, once they had a lot of webinars and then sensitized the COVID care teams that these are the symptoms and signs of mucormycosis, they're getting early cases. And in Aurangabad, just today I was speaking to an ophthalmologist who is in charge of this particular multi-speciality team. She was very clear in mentioning that they're getting early cases and they're able to take care of them just by doing simple sinus surgery and systemic amphotericin B. They don't have to do orbital exenteration. Vision is saved and life is saved. So early cases are the key.
Okay, thank you, sir. And there is a thing going on in the WhatsApp University about the methylene blue. Using methylene blue. Is there any role of methylene blue in the oxygen delivery humidifier bottle, or is it just a myth?
No proof, sir.
No scientific evidence. No
scientific evidence.
Okay. Dr. Anirban, if you want to go on and ask any questions to Dr. Honavar or Dr. Amita Rai Choudhury, there are plenty of questions still coming in. There is one question from Dr. Sudipta Mitra Hugli. She is asking, is total ophthalmoplegia a sign also without red eye?
Yes, white ophthalmoplegia is known in COVID when it directly involves the superior orbital fissure. It goes through the other route. It doesn't have to go to the mid-orbit, posterior orbit, that kind of anterior to posterior progression. If it goes directly into the orbital apex, superior orbital fissure by the route that was being described by one of the speakers, foramen rotundum, etc., then possibly a white-eyed ptosis, white-eyed ophthalmoplegia is possible, and we have seen those patients.
Thank you, sir. There is a question from Dr. Devarati Mukherjee, Calcutta. She is asking, in which patient or when should we give retrobulbar amphotericin and what dose?
The retrobulbar amphotericin is specifically for patients where there is reasonable or good vision and the posterior orbital part is involved, not in the mid or anterior orbit, where you don't want to do exenteration because the patient has vision and has limited disease, yet you want to take care of mucormycosis that is in the posterior orbit. Provided on MRI there is vital tissue. If the entire tissue is devitalized, then that may not help. Even giving retrobulbar amphotericin may not help. If there is vital tissue, then systemic as well as retrobulbar amphotericin is supposed to help, given in the dose of 3.5 milligram per ml on 7 consecutive days. But it can cause compartment syndrome because it can, because of the high molecular weight, it draws water and causes orbital edema. But if the patient has already undergone FES, there is orbital decompression and there is a route to egress for this edema. So compartmental syndrome is not known to occur if the patient has already undergone a sinus.
The route of injection is superomedial, Santosh?
You can give any, you like giving a retrobulbar injection, transcutaneous retrobulbar orbital injection.
Inferior or superior, doesn't matter.
Doesn't matter.
Okay.
Anirban, you want to ask any questions to the panelists and to the speakers? Anirban?
I gone through the all question, but
no, not yet.
No.
There are a lot of almost.
There are loads and loads of questions. So some of these questions have actually been.
But as many questions has already answered by the
so we are skipping them. Dr. Niladri Shah from Malda, West Bengal, is asking: can we start oral therapy in every case?
Oral therapy of?
Posaconazole.
Probably, I think he has been posaconazole as prophylactic.
Extremely expensive. Posaconazole, isoconazole have to be reserved for patients where you have an extremely high risk of developing mucormycosis. That is as prophylactic therapy, but there is no scientific evidence to date. It is only being proposed. But continuation of step-down therapy with posaconazole after finishing off with a course of intravenous amphotericin B is recommended.
Thank you, sir.
And also liver toxic.
Correct. It's extremely expensive.
Dr. Nilay Majumdar, he's asking about the incidence of mucormycosis in COVID patients who are not having steroid and also who are not diabetic or not immunosuppressed.
Correct. So,
have you seen any such patient?
yes. In the beginning, we thought that only immunocompromised patients who are diabetics or received good dose of steroids and oxygen are prone to it. But very recently, we are getting young patients in their 30s and 40s, home cared, no oxygen, no steroids, no steroid inhalers, nothing, no risk factor, still developing mucormycosis within 1 week after testing positive for COVID. So there is a connection which is directly to the virus, bypassing all the other risk factors that we think are risk factors. So this is very perplexing, and these patients are there.
Okay. Dr. P.K. Singh from Kolkata is asking again, Dr. Sanyal has touched upon this question. As a general ophthalmologist, what to observe? What clinical examination should we do to a patient coming to us to rule out mucormycosis infection? In fact, to be honest, I had a patient yesterday who just reading the newspaper came to me, who is a patient of a different consultant who was there a couple of hours later, but didn't want to wait, just want me to see whether he had mucormycosis or not. So as well, reading newspapers and Google, patients are getting. So what sort of investigations or examination as a general ophthalmologist should perform? I think you have already touched upon it, but if you want to add anything else.
I think they should just be aware of signs and symptoms. And Arvind Pondicherry has put up a leaflet which lists 10 signs, A to M or whatever, alphabetical order.
You have
It's
posted
there
also
out.
that.
Yeah. So that is one thing that you can, use, that they are trying to distribute in COVID care centers as a along with their discharge. So patients are aware that if they develop any of those symptoms, they should seek consultation directly with an ophthalmologist or an ENT specialist. But this could be a list of symptoms that could be watched out for general ophthalmologists as well. If they have a patient who has periocular swelling or hyperesthesia or nasal discharge, which is blackish, or nasal, epistaxis, which has blackish tinge, or dental pain, all those symptoms which are there, out there, 10, 20 symptoms. If they encounter any patient with those symptoms, they should immediately seek the help of an ENT surgeon in their locality or an oculoplasty surgeon who's at a higher center.
Thank you, sir. Arup, you want to ask some of the questions, or shall I carry on?
You carry on. So I think we have to
wind up within
just couple of minutes.
Dr. Hanover can spare few more minutes. There is a question from again Dr. Sudipta Mitra. Should we suspect mucormycosis in a patient who is presenting just with pain in the eye post-COVID, which is not tolerable, but there is no redness, no ptosis?
Pain worsening pain associated with hyperesthesia, pain associated with ocular motility restriction or diplopia, loss of corneal sensation, etc. Just pain, constant pain, which is not worsening, may not be related to mucormycosis. Those are wrong, bells that are rung, because pain is a symptom, but steady pain or pain that goes away with a painkiller is not a reliable symptom.
There is a question by Dr. Piashen, Kolkata. Any prophylactic treatment for COVID patient to prevent mucormycosis?
Prophylactic only for very extremely high risk patients. I already enumerated the indications, but that is not scientifically proven. Let me tell you that. And we cannot give it to everybody because the incidence is very low. It's like, screening general population which has no risk of developing glaucoma for glaucoma. Like if you start screening 20-year-olds for glaucoma, then you'll not get a diagnostic yield at all. So you have to define what kind of patients you want to screen. Similarly, what kind of patient population you want to give prophylaxis to, then you may get some benefit, not everybody.
There is a question from Sugato Maiti from Tolmluk. Is there any reported case of mucormycosis pediatric age group?
Mucormycosis pediatric age group has been reported in the presence of COVID, yes. 12-year-old child.
12-year.
There is a question from Dr. Pranab Chakravarti from Nagaon, Assam. What percentage of the patients are losing their vision from mucormycosis? Any idea from the panelist or from Dr. Honavar, sir?
Yeah, from the cases that we collected, about 70% of patients presented with loss of vision as their symptom. So obviously they have lost vision. And during the course of treatment, additional 5 to 10% may lose vision because of optic nerve compression. And as a consequence of aggressive ENT surgery, also patients may lose their medial rectus and vision because it's all necrotic tissue, and it's sometimes very difficult to localize the optic nerve unless you do a navigational surgery. So, but then that is pardonable because you're talking about salvage of life, right? So that is possible. Loss of vision is definitely one of something that is on the plate and patient can lose. But if patients present with early symptoms, then it is possible to salvage vision. So if the patient presents in the stage of sinus involvement, nasal involvement, vision definitely is a possibility. Once it is reached the orbit, then stage 3 and 3B are okay. But beyond that, there is central retinal artery occlusion, ophthalmic artery occlusion, and vision cannot be salvaged.
Okay, thank you. There is a question from Dr. Alokesh Ganguly, Kolkata. Now, as we are talking about steroid, does it include the inhalation budesonide as well, which is a causative factor? Because budesonide inhalers are used aggressively in during the second wave, I believe. Can that be a cause of more mucormycosis, or is it oral and intravenous steroids?
Oral and intravenous are incriminated. Budesonide has been used very recently, it has been approved. So we don't know whether it really causes or not. And it is not used in isolation. It is used along with oral steroids and intravenous steroids. So we really don't know which is incriminated.
Inhalation and topical steroids in the nose and inhalation steroids are hardly absorbed in the body. So I don't think so.
Sorry, they are hardly absorbed, but they are can they cause localized infection?
It's immunosuppression.
If they don't enter your system, I mean, of course they can cause localized problems. I mean, we have seen people with steroid inhalers having fungal infection, maybe candidiasis, if they don't wash their mouth properly. But apart from that systemic infection, there must be something else going on.
Okay.
I don't think
this for Dr. Arjun from Dr. Anshuman Goswami. What kind of anesthesia is used for such extensive debridement? Can general anesthesia be used safely in patient with already compromised lung function?
The anesthesia is a very big issue. I think Dr. Santosh highlighted on that point as well. Making them look stable is one of the most difficult thing, and that we may lose time, and also preparing them. Like in a COVID patient, there is a specific hour for doing the CT and MRI, and that is usually in the night. So basically, we are losing time in there, and that's talking from practical experience. As Dr. Santosh rightly mentioned that it can be done under local anesthesia because these are devitalized tissues, and they hardly bleed, and they are not sensitized as well. So yes, it can be done under local anesthesia to start with. It will be kind of make them a little bit more stable and go for a general anesthesia for a more extensive debridement.
Yeah, for orbital exenteration, at least some of my colleagues in Bangalore have done it under local or no anesthesia because tissue was so devitalized that the patient did not even wince when orbital exenteration was done. And this exenteration is not as difficult as oncology exenteration. This can easily be finished. Once a surgeon has done 5 to 6 cases, this can be finished in 15 to 20 minutes because there is subperiosteal effusion. Periosteum simply peels off. There is no bleeding, and you can finish exenteration very, very quickly if you don't want to spare the lid. But if you want to do a lid sparing exenteration so that you can line the orbit with some tissue, then that may take time. But anesthesia is absolutely not a problem. Local anesthesia is absolutely fine for orbital exenteration.
We have done endoscopy.
But general anesthesia more comfortable in case of nasal.
Yeah.
General anesthesia is more comfortable in aspect to ENT surgeon because the maxillary sinus, nasal cavity, borderectomy, pterygoid plate, posterior part of the maxilla, very difficult to access through local anesthesia. It is more comfortable with general anesthesia.
I think question from Shougata, because this is from Kolkata. Is there any alternative drug in patients who have very severely affected renal function?
Posaconazole and isovolaconazole, but the posaconazole is hepatotoxic. But in renal function alteration, posaconazole is the preferred drug.
Thank you, sir. So Anirban and Arup, over to you. There are a lot of questions, but it's very difficult to answer all of them. But quite a lot of those questions are being answered by Dr. Honavar in his presentations, like the dose of amphotericin B.
Yeah. And I think Sugato, the IGO is coming. Already we got every member of AIOS got the mail from Dr. Honavar regarding the.
I would request all the members to subscribe to OSWB YouTube channel, and this will be there in the YouTube channel, and they can again go through the presentation of Dr. Honavar and Dr. Amitav Rai Choudhury and also Dr. Arjun Dasgupta in future as well. So over to you, Arup.
Just it's a time to end of this session. It's a wonderful session. The doctors from all over India, almost there is a 300 participants in this webinar. So I must thank Dr. Honavar to kindly spare his time. He's very busy during morning. I call him and he's in different meeting. At least whole day is doing meeting. And thank you, sir, once again. And I must thank Dr. Amitav Rai Choudhury. Instead of his illness, he is sparing time with us and sharing knowledge. It's a really enlightening lecture. And I must thank our leader and friend, Dr. Arjun Dasgupta, for excellent presentation and overview of management, and all the panelists, Dr. Tushar, Dr. Joyita Das, Dr. Saurabh Sharnal, and Dr. Rajesh Mojumdar Choudhury. And I also thanks Sun Pharma, Avista Division, kindly sponsoring this session. Thank you. Thank you so much.
If Dr. B.K. Shatkar wants to add anything, Arjun, Arup, is it there, Dr. Shatkar? Sir
is not there.
Sir was not well as well. Okay, yeah. Sir is not there. Yeah. So we can close the meeting. Thank you, everyone, for sparing your time on a Sunday.
Once again, you must subscribe to OSWB YouTube channel. You can see the whole presentation in YouTube. And
my last suggestion is that please form the team. Yeah. That is very important.
Yes.
Listening to lecture will not serve this patient.
Absolutely, absolutely.
Yes, but Arjun has shown that there is a way, and the good way of debridement. Arjun's surgery has given us the hope that, okay, we have surgeon even in Calcutta who can debride, and there are good oculoplastic surgeons who can do the bad surgery of exenteration to at least to save the patient.
Joyita can do in 5 minutes. Yeah. One can do in 5 minutes. So.
Yes, Joyita, Anirban, Rajesh, Dr. Chandana Chakravarti. There are a lot of surgeons here in Calcutta.
Yeah. I think before we end, can I just say a few words?
Yes, yes.
See, we face a problem. I encountered a mucormycosis patient who was sent to medical college simply because this patient couldn't afford treatment. So we need centers where these patients can be treated, beds where they can be admitted. That is a problem that we are facing. Dr. Honavar has raised the alarm of the drug. The drug is not available in Maharashtra now. There's a scarcity in Karnataka. These are the problems we're facing, and we don't have much time. The patients are beginning to trickle in. So we have to get our act together as soon as possible. Combine to make these teams, sensitize the government to set up facilities in government institutions as well, and ensure that the drug is available. How much time do we have?
We have very little time, Anirban. That's very alarming. But at the same time, I was speaking to Sun Pharma higher authorities. They say that they have amphotericin in their manufacturing pipeline, but they manufacture very little of it because it had limited uses. So requesting such a pharmaceutical company which has such a wide range of activities and who have a very deep batting order to augment amphotericin production. Sun Pharma is the sponsor. Probably one of you can send them an official request through proper channels. So they augment production of amphotericin. They have a capacity, they have the drug. They have to simply market it.
Thank you very much, sir.
Thank you.
Thank you.
Thank you very much.
Thank you so much. Yeah.
Thank you very much.
If we can close the transmission, Rohit from the support team, if we can stop the transmission.